I don't think it'll surprise any of you to hear that asthma is frequently tested on the shelf, so we will briefly hit through some high points and some things that I think you should be aware of. I'm not going to perseverate on anything too much here. So, just to know how you diagnose it. Obviously, you all probably remember the spirometry patterns and know how to differentiate it from COPD, and that there's no inability to um, diffuse. There's no loss of lung function, at least initially. Um, and I think the key thing here to keep in mind is that if they come in with symptoms, you can reverse them completely or mostly with bronchodilator therapy. And remember the methacholine challenge, something that we can do for these people, and lower doses of methacholine. Methacholine will make a normal person have a reactive, bronchoconstriction, but remember that asthma patients will require a lower dose to achieve some irritation in the airways. So just remember on their exam, wheezing, right? So, but if it's mild, it's going to be only at the end of expiration. As it gets worse throughout expiration, and inspiratory and expiratory wheezing would be a fairly severe asthma attack. So be able to use those exam findings when you read a question, and think, this is a more severe exacerbation than another. And then lung hyperinflation is the key finding on the chest X-ray. And I'm not going to dig too far into this. I think I just wanted to point out a few things, and intermittent is the one here that sticks out sort of on its own, just that they really only have symptoms that require a rescue inhaler occasionally. And I think that moderate persistent and severe persistent are ones that you can really start to differentiate pretty easily. I think that when you have moderate persistent, it's easy to remember that they're the ones who have a mildly reduced FEV1 that's still greater than 60%, even when they're asymptomatic. And severe persistent, remember that they're going to have symptoms throughout the day, whereas moderate persistent has daily symptoms, but not necessarily all day. And with severe persistent, their FEV1 is below 60, which is about as bad as it would be at the beginning of COPD diagnosis. Okay. Then just some tidbits that you'll want to know that inhaled steroids can improve mortality. You'd be surprised, but they like to ask questions to see if you know which medicines actually have sort of a research-proven benefit in mortality and morbidity. And the opposite is true with the long-acting beta agonists like salmeterol, formoterol. Those are actually associated with increased mortality. Had a black box warning for a while. They're still used for people who have moderate or severe persistent asthma, in addition to the inhaled steroid. But you should always use inhaled steroids over long-acting beta agonists when it comes to asthma patients, which is the opposite of COPD treatment. And unlikely you're going to see this on the shelf, but somebody who's maxed out inhaled steroids and long-acting beta agonists is someone who could use oral prednisone daily. That's really going to be hard to test you on, though. But do remember that someone who comes in with an acute exacerbation of asthma, they need steroids, probably oral steroids, presuming it's not really severe. And just go through a few examples. This is somebody who had a URI, fever, and cough, and now has worsening wheezing and shortness of breath for the past several hours, and it's not being fully relieved with a rescue inhaler. So she's having an exacerbation. And what should we do when somebody, is having an asthma exacerbation? So should we admit her? Should we start oral corticoids as an outpatient, start a daily steroid? And the answer here, this is pretty mild. It's a mild exacerbation. She's had a cold. So I think we can just give her oral steroids, treat her as an outpatient, send her home, and you probably give her a breathing treatment while she's in your office or in the ER with, nebulized albuterol or ipratropium, just an anticholinergic medicine. And another one here. So this is someone who looks like they're going from intermittent to more of a mild persistent pattern where they're waking up 3 times each month, but not necessarily every week. And the key here is that he's had 3 exacerbations that required oral steroids the past year, which is more than 2, which is what bumps you into that mild persistent pattern. but normal spirometry without symptoms. So should we start a steroid, oral or inhaled, or should we continue current treatments, which seem like they're inadequate? So best answer here is going to be to he's someone who has gone from intermittent to mild persistent and needs maintenance daily therapy with an inhaled steroid. All right, and I just told you why. So in another one here, this is someone who is already starting to have some spirometry deficits when she's asymptomatic, but her FEV1 is greater than 60. So again, that's going to be moderate, persistent, and she's having symptoms daily. And I just asked you to classify it here, and I already told you she's moderate, persistent would be the answer here. Um, and this is someone who will probably already have been taking uh, inhaled steroids, and you could either add a bronchodilator or like an anticholinergic bronchodilator, or or a long. So, sorry about that. So you could add a long-acting beta agonist here, or you could increase your inhaled steroid dose. Either one would be appropriate, and they can ask you to differentiate between those two on the shelf. Okay, just redefining severe persistent there. I don't know why I did that twice. Sorry about that. So this is something that you need to make sure you know and be very aware of going into the test is how can you predict who's potentially going to respiratory failure with an asthma attack. And here are some of the features. Someone who on their arterial blood gas has a normal or elevated PCO2, but on the test it's always going to be normal because they want you to realize that it should be low. They should be hyperventilating, and if it's normal, it means that their respiratory muscles are fatiguing out and they're about to crash. So you should intubate somebody whose PCO2 is normal. And if you're examining someone who appears to be having a severe attack and you can't hear any wheezing, then that could mean that the bronchoconstriction is so severe that it's actually completely, blocking the airways. And if the respiratory rate slows, that's probably a less, I'm not sure how well they could test you on that. And if you're giving someone high flow oxygen with the nasal cannula and it's still not maintaining a good saturation, then that's someone who is probably going to need to be mechanically ventilated as well. And in COPD patients, you can try the non-invasive CPAP before you intubate, but with asthma patients, you should just go straight to intubation. Um, and this is just a sort of a case that it's a variant of asthma that you need to be aware of. And so this is somebody who comes in and they look like they have asthma, they're wheezing, and everything sounds like asthma, but you treat them for asthma and they don't get any better. And this is a case of vocal cord dysfunction where you have paradoxical adduction of the vocal cords and it causes inspiratory wheezing. And I think you just need to be aware of that because I think they like to ask you about this and try and trick you into picking, asthma or something about asthma. It's a great way to trick you is all I'm trying to say. All right. There you go.